we're just going to talk briefly about female sexual dysfunction. And we're first going to define exactly, medically what sexual health and wellness is. And then we're going to discuss how, even though you've got a definition, it's still unique to each individual. We'll discuss the current medical terminologies for female sexual dysfunction and also the limitations of these terminologies. Then we're also going to look at some of the biopsychosocial models that are used to promote sexual well-being in women, discuss the potential evaluation and treatments of this problem, and also we're going to introduce this concept of a multidisciplinary approach to addressing sexual problems. So the WHO, which is the World Health Organization, in 2002 basically defined sexual health as a state of physical, emotional, mental, and social well-being in relation to sexuality. It's not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. So sexual health is important. It's an integral part of just being human. It's important, obviously, for reproduction. It helps with relationships. And we think it's also important just for the general overall health of people, too. So what is sexuality? It's an experience and or expression of an individual as a sexual being. And it's a complex interplay of sex, gender identity, gender's roles, as in what are social and behavioral norms, as well as sexual orientation. And the most important thing is that sexuality can be different for each person, and it may also vary in one's own lifetime. And the definition of sex, well, it's difficult to define, and it also varies from individual to individual. Now, there's this assumption of penile vaginal intercourse, but other activities can be involved. And intercourse is not necessarily the goal in sexual functioning of some individuals, nor is it necessary. But what is important is that the sexual encounter is safe, healthy, and gratifying. So there are some sexual response models that we look at in medicine. Master and Johnson has this linear model that we'll go over. There's a triphasic model, and then there's an intimacy-based model. So basically in 1966, Masters and Johnson's published a book called Human Sexual Response. And it's basically a linear model of sexual response, and it applies to both men and women, and it's composed of essentially 4 stages. There's excitement, there's plateau, there's orgasm, and there's resolution. And it's just this linear thing where you go from 1 to the 2nd to the 3rd to the 4th. Now, later, the authors Kaplan built on the work of this model. However, theirs consist of separate, but this time they're actually interlocking phases, and there's desire, arousal, and orgasm. And there's a belief that sexual difficulties, typically at this point in time, they believe that it came from superficial origins. And so this is their model where you see there's desire, excitement, and resolution. However, they do interlock, but again, there's this linear essential model. This is a model that we use more often. This is a cyclical model of sexual functioning, and there's many points of entrance into the female sexual response cycle, and all of them overlap. This model actually acknowledges that women may initiate or be responsive to sexual stimuli, where all the other ones were basically only responsive. And it's not only because of arousal. And of significance in this model is that desire is not always first before arousal or the sole reasoning for engaging in sexual activity. So basically, this model is no longer linear, and that there are various points where you can enter into this model of sexual activity. Now, unfortunately, there are limitations to all these models. First, they focus on physiology, and we all know that sex is more important than that. They are unfortunately based on male models, And it also employs a set of paradigms where the requirements that normal sexuality consists of desire, arousal, and orgasm. And if these are deficient, then sexual dysfunction is diagnosed. However, if they are present, then the assumption is that you don't have sexual dysfunction. Now, there's something we need to talk about briefly. It's called the Female Sexual Dysfunction Manifesto. And basically, there is this fear that there is medical, like the women's sexual dysfunction is becoming basically dominated by pharmaceutical companies, and that the disease doesn't necessarily exist. And part of the issue is that there's this fear that basically they're going to create a medicine and then market a disease that doesn't exist. And that's kind of the concern a little bit, and that's basically where we need to understand that female sexual dysfunction does exist, but we don't want it to be hijacked by the pharmaceutical companies. So sexual problems are common, actually. They're in 43% of women and 31% of men. And female sexual dysfunction is basically kind of divided into sexual desire disorders, arousal disorder, orgasmic disorder, and then sexual pain disorders. So in sexual desire disorders, there's a sexual aversion disorder, and this basically is a persistent or recurrent aversion to genital contact with a sexual partner. And it's characterized by a disgust and repugnance towards sexual activity. Then there's something called hypoactive sexual desire disorder, which is a deficiency or absence of sexual fantasies and desire for sexual activity. And this is considered to be beyond the normal reduction expected, with the relationship duration and life cycle. And the sexual performance may be adequate, however, once activity has been initiated. And we only define this or treat this if it causes personal or interpersonal distress. We don't treat it just because it's a disorder. It has to have that distressing factor. Female sexual arousal disorder, unfortunately, also has a name called frigidity, but it is the absence, impairment, or diminishment of genital responsiveness to stimulation. And it's most notably by a lack of adequate lubrication to engage in intercourse. There are subtypes. There is a combined arousal disorder, a mixed arousal disorder, and a genital arousal disorder. And again, the disorder has to cause personal or interpersonal distress. And one of the largest criticisms of female sexual disorder is whether it's an actual disorder or, again, like it's being put forth by the pharmaceutical companies, because this is the area where the pharmaceutical companies are trying to develop a drug. And there is this concern also that, if a drug does come, it would be potentially $1 billion industry. And so we're trying to manage these disorders without letting it get hijacked by the pharmaceutical companies. Now, female orgasmic disorder is basically the persistent or recurrent delay in or absence of orgasm following a normal excitement phase. It is common for women to be able to achieve orgasm with specific forms of stimulation, but not with intercourse. And this is considered within the normal range of sexual dysfunction. And then there's also sexual pain disorders, and this is basically persistent, recurrent urogenital pain that occurs before, during, or after sexual intercourse. And the pain is experienced either as occurring on entry to the vagina or deep pain. Now, psychological and biological factors can contribute to this condition, and you can think of it as a pain disorder that interferes with sexuality, as opposed to a sexual disorder characterized by pain. This is another form of sexual pain disorder. It's vaginismus. It's an involuntary tightening of the outer third of the vaginal muscles to the extent that vaginal penetration is very difficult, despite the woman desiring penetration. And women with this condition can still achieve orgasm and enjoy sexual activity, but just not the penetration. Now, it's not always present in all situations. And although it is considered a pain disorder, most women don't feel pain since penetration is actually almost impossible. Now, there is problems with all of these terminologies. First, they're based on this linear sexual response model that focuses only on physiology. Second, there's a negative connotation to some of them. They're also vague, they're kind of subjective. And as we all know, sexual problems are relative. It's not like you have one and you don't have one. So on the flip side, unfortunately, we need the terminology because it gives us a common language for clinical work in research. And it has to be done sometimes to legitimize women's sexual health concerns because, you know, up until now, male sexual dysfunction has really dominated the health spectrum. Now, there are current efforts to improve the terminology. We are considering regrouping the disorders into sexual interest / arousal disorders, and then to put them into female orgasmic disorder. And the last one would be genital pelvic pain / penetration disorder. So this is a lot. But basically, in the sexual interest arousal disorder, it would be a lack of sexual interest arousal of at least 6 months duration as manifested by at least 3 of the following indications. Reduced frequency or intensity of interest in sexual activity, reduced frequency or intensity of sexual erotic thoughts and fantasies, an absence or decreased frequency of initiation of sexual activity and is typically unreceptive to a partner's attempts to initiate, a decrease in the intensity of sexual excitement / pleasure during sexual activity, which would be approximately 75% of encounters. Sexual interest or arousal is absent or infrequently elicited by any internal or external sexual erotic cues. There is an absence in the reduced frequency or intensity of genital and or non-genital sensations also. Of course, we would only treat the disorder if the problem causes clinically significant distress or impairment. And that it's not better characterized by some sort of basically axis 1, which is a psychiatric disorder, or it's not a result of substance abuse or a general medication. Now, there are subtypes of the sexual interest / arousal disorder. There's going to be the early onset, which basically is someone who's had this their whole life. And then there's going to be the late onset, which is basically someone who acquired it. And we're going to look at whether or not that disorder is generalized versus just in certain situations, whether it's related to partner factors such as a partner's sexual problems or a partner's health status. Also, in terms of, we would have to look at relationship factors. Is there poor communication, relationship discord, discrepancies in desire for activity? There's also individual vulnerability factors, poor body image, a history of abuse, or psychiatric comorbidities, depression, anxiety. And then you also have to focus on cultural and religious factors. Are there inhibitions related to prohibitions against sexual activity in that person's culture or religion? And also look at medical factors relevant to prognosis, course, or treatment. Now, in terms of female orgasmic disorder, this one we suggest is at least one of the 2 following symptoms, when the symptoms must have been present for at least 6 months and be experienced on all or almost 75% occasions of sexual activity. And there's going to be a marked delay in or marked infrequency or even complete absence of orgasms, or a marked reduced intensity of the orgasmic sensation. The problem causes clinically, again, significant distress or impairment. And again, it's not better characterized by a psychiatric illness, medical abuse of drugs, or another medical condition. And again, this again is also divided into early onset, as in people who've actually never had an orgasm their whole life, or late onset that did have them at one time, but then later started having issues. And again, you've got to look at the same things that you looked at before. Is it generalized, situational? Is it based on, partner factors, relationship factors, poor body image, history of abuse, cultural reasons? And those are also important to look at. Now, in terms of the pelvic pain penetration disorder, this is a persistent or recurrent difficulty for at least 6 months with one or more of the following: an inability to have vaginal intercourse / penetration, marked vulvovaginal or pelvic pain during vaginal intercourse or penetration attempts, a marked fear or anxiety either about vulvovaginal or pelvic pain or vaginal penetration, and a marked tensing or tightening of the pelvic floor muscle during attempted vaginal penetration. And again, we want this problem to cause distress or impairment before we address it. And it's the same things. We look at whether you've had it your whole life or whether it occurred later in life, and we look at the same specifiers again. So there are, at this time, significant obstacles in the diagnosis and treatment of female sexual problems. A, there's a reluctance of patients to talk about it. B, care providers avoid the topic. We don't know if it's because of a lack of time on the care provider side or a lack of knowledge. There are also underlying etiologies are poorly understood, and often they're multifactorial, so it does require a lot of time by the caregivers. And at this time, unfortunately, the treatment options are also limited. So the biophysiosocial model is kind of the approach being used to the management of female sexual dysfunction. Sexual problems can develop because of biological reasons, physical reasons, psychological reasons, social reasons, or even a mixture of all of these factors. Now, the biological factors may interfere with sexual function, include such as medical problems, hormonal changes. There could be medications that are a culprit. Psychological factors could be anxiety, depression, stress, abuse, poor body image, or memories of sexual trauma that greatly influence how a person functions sexually. There also are social and interpersonal factors that affect function, including relationship problems, religious beliefs, cultural beliefs, and also one's general upbringing. So basically, you've got these four things that can all contribute to female sexual dysfunction. And when you address female sexual dysfunction, it's important to address all of these factors. So at this point, in terms of diagnosing and management, first of all, at this point, we really do depend on the patient complaining of female sexual dysfunction. And then there's a basic evaluation that the care provider would, do: a sexual history, a medical history, a psychological history, a focused physical exam, and then some lab tests. Check the thyroid, check your hormone levels. And then we see whether the findings indicate further specific evaluations. Do you need a pelvic ultrasound, urodynamic study, cystoscopy? Are there other tests indicated? If there aren't any other findings that do not preclude treatment, then we can do patient partner education, or we can just focus on the patient too. We don't even need to involve the partner, and do some shared decision making in terms of how we want to come up with a treatment plan. So in terms of taking a sexual history, this is actually very challenging for a lot of physicians. The interview needs to be open-ended. Start with open-ended questions and then go to close-ended questions, which is kind of not really how physicians are taught to take in history to begin with. Obviously, listening carefully to their response, not just going through a checklist, and ask clarifying questions when the responses are vague. Make sure that the patient actually understands the terms you are using. Modify questions to suit the situation and/or response. Again, we just don't want a checklist of questions. And all the questions relating to sexual practices must be free of any assumption of sexual orientation or monogamy. You can't have a physician going in with certain, thoughts of how things should be. Now, in terms of the treatment options, in desire disorders, we focus on relationship marital therapy, cognitive behavior therapy. There are some medicines that we're looking at, bupropion. These medicines you probably haven't heard of, but there's also testosterone that we're looking at too. In terms of arousal disorders, there is also a focus on pelvic exercises and pelvic physical therapy. There are clitoral therapy devices, and there are also a list of medicines that we're looking at too. In terms of orgasmic disorders, there's directed masturbation. There's anxiety reduction techniques. There's also just the concept of sexual education. Some women just don't know that they can have an orgasm. There's also medications available. And in terms of pain disorders, there's sex therapy, there's biofeedback training that can be done with a pelvic physical therapist. There's also surgical interventions if necessary. There's also acupuncture and various medications that can be done. But I would say the most important things is really, your ear, basically to listen to whatever, the patient says. Education, physicians need to be educated on basically, some of them just basic anatomy and physiology of women. And then also, to have realistic expectations of what you're going to be able to do to help the patient. But the goal should always be satisfaction, not necessarily what you perceive sex should be. And then also empathy in terms of recognizing the role of grief and loss. So how do we manage these problems? So we are, unfortunately, we're still establishing this, but there was going to be a multidisciplinary specialty center where we're going to hopefully focus on sexual health and well-being in terms of patient care, research, and education. And then the goal would be to have, you need an OBGYN, you need a urologist, a psychiatrist, a psychologist, and a physical therapist. But the most important thing is getting a team of people who demonstrate a commitment and interest in sexual health issues, and that sometimes can be, believe it or not, more challenging than you think, just getting the team together. And that's kind of where we are. The clinic design would be an initial appointment with a urologist and an OBGYN, but you would also have evaluation by a psychiatrist, a sexual therapist, and a physical therapist as indicated. And then a meeting where everyone gets to sit down together and come up with a treatment plan, and then give the treatment plan to the patient and see whether or not they want to implement it. And so in conclusion, sex is an important part of well-being. Sexual satisfaction should be a goal. Sexual wellness can be achieved by using a biopsychosocial model for assessment and treatment. And there is help for this. We're just kind of getting there slowly. So, all right, well, thank you for your time.